Thank you, students, for that energetic and amazing performance. You really added a burst of freshness to this session. As the rhythm settles and applause fades, let us return to our session with renewed attention. I request Umasankar sir to proceed the scientific session and Narendra sir to chair this session.
Hello, hello. Volume টা দেন হ্যাঁ ঠিক আছে models please come. Fine. Okay. এটা ওটা ঠিক হলো skeleton. Please make it straight and sit down. That was a very wonderful performance. Where are the performers? We will clap for them. Huh? I asked Mona Madam that if the students are from Andhra Pradesh, so they did on Telugu songs, but very nice songs. But we are I really like the song selection and the performance also. Okay, so now you got a break away from my scientific talks. So we'll resume it now. We are discussing about the anterior rotation dysfunctions, right? So in anterior rotation dysfunction, the ASIS is down. ASIS is down, PSIS is up, and the Gillette test is positive. So please increase the sound little bit. Okay, okay. Right, right. Little bit more. Okay. So I demonstrated first technique in crook lying position, the posterior rotation. Okay. In crook lying, I think we'll bring this one here, like previous position. Let's bring this one here. To the right of the hold it from that side. Huh? Keep it here. Okay. Make this one straight. You know how to make it? Okay. Fine. What's it? 80. Now get the pillow and lie down. One of you become model. Bring one pillow. Now who was the model last time? Lie down. Soja. It is a put on it is lie down. Supine. Okay. So come to crook lying. So first technique, what I discussed was putting the PC form inferior to ASIS, applying the force, posterior, superior and lateral. Okay. Number one technique. Number two, crook straight position, Chicago technique. Lower extremity is crossed, upper extremity is crossed, convexity created, trunk rotated to opposite side, PC form, inferior to ASIS, go to the barrier and give a thrust. Third technique, come to crook lying. Crook lying position, forearm, distal posterior aspect of the thigh. Asking the person to take the hip for extension, okay? Down, press down. 1, 2, 3, 4, 5, 6. Relax. And we are repeating for 6 to 10 times. This much we discussed. Next is, I will show you another method in side lying position. Come to side lying, left side. Lie down on your left side. Move front, okay? Please pass one pillow there. You place the pillow. Why the pillow is placed? Therapist has to flex the hip and knee. I am stabilizing the posterior aspect of the sacrum so that when we mobilize or we give the thrust, it goes to the SI joint. Subject in side lying position, the sacrum is stabilized. Because sacrum is in the middle, So we need some elevation. That's why I am putting the pillow. Next, hip is flexed for 110 degrees. Okay. What will happen? See, after 90 degrees, it will move for posterior rotation. After, see the mechanism. After 90, it has gone for anterior rotation dysfunction. Once you are taking above 90 degrees, then muscular pull will be there. Posterior muscles will pull, it will move for posterior rotation, that means towards the neutral position. Okay? And then you add the adduction component. With adduction component, the joint is going to open up. Okay? Now, hip is flexed, 110 degrees, fingers interlocked, put it in front of the knee joint, adduction for 20 degrees. Take it for 20 degrees of adduction. Then you mobilize along the long axis of femur. Mobilize along the long axis of femur, go to the barrier, you give the mobilization, about 6 to 10 glides, and then go and give a thrust. Okay? So this is the side lying mobilization and manipulation technique. Okay? So what happens exactly? What is the mechanism? After 110 degrees, it starts moving for, it has gone for anterior rotation dysfunction. It will start moving towards the neutral position. Once you add the adduction component, the joint is going to open up. Now, if I show you from this side so that you see what is happening. Now, it moves, it has gone for anterior rotation dysfunction. Once you are taking it for flexion further, it is moving this way and it is opening up with adduction. That is what we are more interested in. As I told you that majority of the receptors in the SI joint are located in the posterior aspect of the joint. So, because it is getting irritated, when there is anterior rotation, it is going to compress the joint, so you are opening it up. So these are the techniques for the anterior rotation dysfunction management. Next, coming to the posterior rotation dysfunction management. In posterior rotation, we have got a flat back. Posterior rotation, there is a flat back. And in case of disc balls also, in disc balls what is happening? The lordosis is getting obliterated. It is going for a kyphosis. Okay? So certain techniques of the pelvic complex can be utilized with the lumbar spine dysfunctions. Because their lumbo-pelvic complex influence each other. The pelvis will influence lumbar spine will influence the pelvis. Okay. Now coming to posterior rotation dysfunction, what is the finding? The PSIS is down, ASIS is up, and the lordosis is obliterated. Okay. So posterior rotation dysfunctions are also not that uncommon. Common dysfunctions are upslip, anterior rotation and out flare. Posterior rotation also problems we do get, especially as I told you along with disc balls cases. So come to crook line. Good chair trying to rakh the weight. So in crook line, as I told you that in case of anterior rotation dysfunction, we are applying the posterior rotation mobilization. Similarly, in case of posterior rotation dysfunction, we are applying the anterior rotation to correct. So how to apply the anterior rotation? So to show you the exact placement, the ventral aspect of the palm is kept at the superior aspect of the anterior 1/3 of the iliac crest. Superior aspect of anterior 1/3 of the iliac crest. The ventral aspect of the palm is kept. And then you apply the force anterior, medial and inferior. The direction of force anterior, medial and inferior. Again, it is not pure vector, it is not pure anterior, medial and inferior, it is a resultant in a curved plane, you have to apply the technique. Ventral aspect of the palm, superior aspect of anterior 1/3 of the iliac crest, and apply the force towards the opposite side knee joint. Force is applied towards the opposite side knee joint. You imagine we are taking one ball and we are trying to roll like this. Okay? Ventral aspect of the palm, superior aspect of anterior 1/3 of the iliac crest. Force is applied anterior, medial and inferior. So, just go to the barrier and give the mobilization. Start with, give preferably with grade 3, and the person is finding difficulty, you can give the grade 2 mobilizations. Again I am telling you, components anterior, medial and inferior, it is not a pure vector like anterior, medial and inferior, it is in a curved resultant, you have to apply the forces. Okay. Next is the thrust technique. Come to prone lying position. No. In the same position, I will finish the muscle energy technique. In anterior rotation dysfunction, we are applying the gluteus maximus forces to correct the dysfunction. Here we are applying the iliacus force. We are applying the force of iliacus. See, iliopsoas or iliacus, especially when we talk about, iliopsoas is working together doing the hip flexion. We are going to resist the hip flexion. Okay? We are going to resist the hip flexion. Now normally the femur is moving, we are going to restrict the femoral movement. Flex it, flex the right side. Give gentle force, 1/3 of efforts, lift it up. 1, 2, 3, 4, 5, 6, fine. So now the iliacus is attached in the iliac fossa. In the iliac fossa, it will pull the innominate for anterior rotation. So posterior rotation dysfunction will get corrected. So what we are doing, see, we can use the crook lying position. You have got a physio ball, we can put it like this, also we can do the technique. This is the one of the best way to do the technique. If it is not there, you can do it in crook lying also. Flex it. 1, 2, 3, 4, 5, 6, fine. Flex. Right. This is the muscle energy technique, MET for posterior rotation dysfunction. Once again, if we recapitulate, posterior rotation dysfunction, what is the finding? PSIS is down, ASIS is up, and Gillette test is positive. We discussed long back about the Gillette test. Those of you who have joined afterwards, I can just tell you, very important test, asking the person to do the hip flexion. We are palpating at the PSIS, other thumb at the sacrum. Normally PSIS is descending down, instead of going down, goes up, test is positive. That shows that particular side is affected. Why it will go up? Because when there is involvement, dissociation is not happening, so hiking is happening, that is why it is going up. So that is the posterior rotation dysfunction management. Next, coming to outflare management. Outflaring. This is outflare. PSIS is more close to the midline. This is one, see, in dysfunction, and ASIS is away from the umbilicus. Gillette test is positive. PSIS more close to the midline, ASIS is away from the umbilicus, outflaring. Inflaring is this. PSIS is away from the midline, ASIS is more close to the umbilicus. Outflare and inflare. Okay? So coming to outflare management. Come to side lying position. In the outflare, once again, this is how the movement happens. PSIS is more close to the midline, ASIS is away from the umbilicus, outflare. Subject in side lying position, ventral aspect of the palm is kept at the lateral aspect of anterior 1/3 of the iliac crest, lateral aspect. And the force is applied anterior and medial. Direction of force, anterior and medial. Go to the barrier, mobilize. And maybe at the end you can give a small thrust. Mobilize and thrust. Come this way, you are mobilizing, right, and giving a thrust. Crook line. Mobilization thrust. Then I will tell you the muscle energy technique. How we are giving a muscle energy technique. Now we are coming to the barrier. We are bringing the hip for adduction and internal rotation. Bringing the hip for adduction and internal rotation. Okay. Now, in case of out flaring, we are having more range of motion for excuse me, can you please minimize the talk over there? One request. You did a great job. Thank you. So, there is a more range of motion for abduction, external rotation. There is restriction for adduction and internal rotation. You go to the restricted position, okay? Go to the restricted position. Then ask the person to bring the hip for abduction and external rotation, okay? Go to the barrier, bring it out, okay? Push it out, yes. 1, 2, 3, 4, 5, 6. Once again, we are recruiting only 30%. Yesterday, Dr. Surjit was talking about Pilates, and he was also telling about the same thing. We are interested in that 30% of the force. Okay, push it out. 1, 2, 3, 4, 5, 6. Fine. Okay. So now the abductors and external rotators will pull the innominate. It has gone like this. It will pull it towards its original position, original functional and structural position. Okay. Now, along with this, what we have to do is, again we have to activate the core. Core activation, you can start with this tabletop exercise. The support here, ask the person to take a deep breath. Okay, take a deep breath. Fine, very good. Slowly exhale. Okay. Once again, a deep breath, slowly exhale. Hold it in middle, hold it in middle. Okay. Now what I will do is, I will pull both the side lateral to the umbilicus to activate the transversus abdominis. A pre-stretch we will do. You give a pre-stretch, you maintain this position and this position, both maintain, and then you can breathe normally. maintain. You have to maintain for 6 to 10 seconds again. Fine. So this is going to activate the transversus abdominis muscle. Okay. Now once again, tabletop, take a deep breath, slowly exhale. Okay. Pull it, maintain this. 1, and then you can breathe regularly. 1, 2, 3, 4, 5, 6. So this is the bracing method. So this is the bracing method. We have pulled it, and the fibers of transversus abdominis are going to parallelly maintain the contraction. Earlier, those again came little late. I'm just earlier we discussed what is the importance of the transversus abdominis muscle. Maybe 1 more minute I will be spending because it's quite important related to the core stability programs, what we suggest. Now, stand here. Just once again a small recapitulation, turn like this. Turn this way, okay. Right. See, the transversus abdominis muscle is getting inserted to the dorsal lumbar fascia, the dense white fibrous connective tissue, and it is going back and it's spreading and getting inserted. Now, when we activate the core muscle, especially the transversus abdominis, I was just showing you, we activated it. It is going to pull. It is going to pull and approximate the spinous processes. Bhaina, namaskar. My senior Deepak sir has come. I think we can welcome him with a clap. please. When I will continue. Yes. So, the transverse abdominis, it is getting inserted to the dorsolumbar fascia, and it is kind of approximating the spinous process. Okay. The two models are there. One is Barthelin model and Grakovetsky's model. Here we are using the Grakovetsky's model, so that the transverse abdominis force is going to help us in activating and providing the stability of the spine and of the pelvis also. Okay, fine. Please lie down. So you can start with this core, then you can go for come to all four. Turn around. Your hand and on the knees. Okay, fine, perfect. Right? Next step, same activities you can teach to maintain a neutral spine. Move, okay, maintain a neutral spine, okay. And then, already once you have taught the person that you are activating it, same thing the person can continue at home. That pulling may not be able to do, but then in addition, as a progress, bird dog, next progress is bird dog. The bird dog exercise where you need to take a deep breath, slowly exhale, okay, hold it in middle, tighten it, take it in, do that, and then lift this hand up, okay, and lift this leg up, this one, okay, fine, right, take it straight, okay. About 6 seconds, and maybe 6 repetitions can be done, down, the alternate side, other side. So these are see this side, you see for him for the right side and you see for left, he is little having difficulty to maintain this. So he is having weakness in one particular side, fine, okay. Then along with that, some other additional exercises to recruit the gluteals can be done, like, donkey kicks, lift it up, okay. So individual hip extension. So these are the core stability programs what can be added. Okay, come to supine line. So we have discussed about till now about the up slip, down slip, anterior rotation dysfunction, posterior rotation dysfunction, and then out flare. Next, coming to the in flare management. In in flare, the PSIS is more away from the midline and ASIS is more close to the umbilicus in flare management, in flare dysfunction. So how we are going to do the management? Crook lying position, okay, and then right side has gone for in flare. So ASIS in the right side is more close to the umbilicus, PSIS is away from the midline. So this is the in flare, okay. So I am considering the right side is affected, left side ASIS medial aspect is stabilized. I am stabilizing the ASIS of the non-affected side. So left side is non-affected, right side is affected. Other hand, pisiform is kept medial to the ASIS of right side, which I have taken to be, that side is affected, right side, okay. Applying a force lateral, primarily lateral, major component lateral and then posterior. Okay, so it is going to correct the in flare issues. So you can mobilize and you can give a thrust. Again, in flare is not that symptomatic because it is not going to compress the posterior part of the SI joint. Out flare is more problematic, but in flare, you see, it is not compressing the posterior part of the SI joint. So clinically, although theoretically existing, but it is not symptomatic. So patient will not come for treatment, okay. So most commonly upslip, anterior rotation dysfunction, out flare and posterior dysfunctions we will be getting mostly in association with the disc bulge cases. So in those cases I will tell you also what you have to additionally do for the disc prolapse management. Okay. MET for in flare. as in out flare, we are having more range of motion for abduction external rotation and restriction for adduction internal rotation. Similarly, for in flare, we are having more range of motion for adduction internal rotation and there is a restriction towards abduction external rotation. So you go to the restricted position. That is the general principle of application of the muscle energy technique. You go to the restricted position and then contract away from the barrier. So barrier is towards abduction external rotation, contraction away from the barrier means it is towards adduction and internal rotation. Now we can take a small support here and then you bring it like this, lift it up, bring it. Already we have shown the movement because patient is not going to understand the technical words like adduction, internal rotation. If you teach too much of technical term, patient won't come next day. मतलब मेरा पेन ठीक है, ये सब technical term, who is going to remember all these things? So you have to simplify it, just show the movement, and so that the person can just repeat that movement, and you can guide. In flare, more range of motion for adduction internal rotation, restriction for abduction external rotation. Go to the restricted position, ask the person to bring it for adduction internal rotation. Okay, they do this movement. Okay. Give the resistance 1/3, 30% of efforts, 1, 2, 3, 4, 5, 6, fine. So come to the new position. Can you just stand up here? I'll show you some beautiful aspect of angle of pull. Stand here, okay? Now, allow a free movement for yourself, right? Not a free fall, free movement, right? Okay. You hold the distal part of the forearm, okay? Now all of you observe here. I am just pulling him gentle. He is coming to which side? To left or right? Left side, right? It's not a very rocket science question. Very simple question. He is now coming towards left side, okay? Maintain. Holding the same grasp, I'll just change the angle of pull. You don't do movement right now, okay? Now I'm pulling. He's coming to which side? Right side. Grasp is same. Angle of pull. That makes a lot of differences. You see now coming to right, but same grasp. Now coming to left. Okay. So here the same principle works. The angle of pull. Okay, fine. You can go and sit down. So we discussed about all the dysfunctions of the innominate, and now discuss about the managements also. Now next I will tell you about the piriformis syndrome, okay. Come to prone line. Quite associated. Okay, before I move ahead, 1 minute, just get up. I think you can just change. You come and goes back. Yes, that you can remove. Now, the lights are there, no? They are quite hot. Still you are feeling cold. Okay. Come to prone line. Prone. Okay. Now, I will tell you some direct techniques for the SI joint. You see, as I told you that we are palpating for the joint just medial to the PSIs in the sacral sulcus. This is the landmark for PSIS. This is the sacral sulcus. Here you have maximum receptors, and this is the area where the person complains of more pain in case of sacroiliac joint. And as per the finding, maybe 2 to 3 centimeter lateral and 3 centimeter caudal from sacral sulcus. This is the area where the pain will be felt. Now, classical clinical complaint of the patient. Patient comes and tells you, symptoms are felt for this joint in weight bearing position. So what is the weight bearing position for sacroiliac joint? Most important is sitting position. Patient tells that in sitting position I am getting the pain, or else patient will tell you from sitting to standing when I am coming, because a dynamic body load is coming there and in different areas. So patient will tell you I am getting the pain either in sitting position, or I am going to sit, or I am getting up from sitting position. Next, Standing also, because standing also load is coming here. Sitting, standing, walking, dancing, running, the symptoms will be felt. But most commonly patient will tell you that when I am sitting and standing or I am going to sit down, I am getting the unilateral pain. Then next step, already I told you that how to identify the palpation, Gillette test, rest of the things we have covered. So a direct mobilization to the sacroiliac joint and a clinical confirmation test also. Not only you have got different tests, but this is one of the very important tests also and treatment maneuver also. You place the PC form or the PSIS and apply the force anterolateral. This is a mobilization technique directly on the SI joint. Force is applied anterolaterally. You can just mobilize, give about 6 to 10 glides, and if at the end you want to give a small thrust also, you can give. Well, I forgot to mention the thrust technique for the posterior rotation dysfunction. Okay, good, come up. Prone. In posterior rotation dysfunction, PSIS is going down and ASIS is going up. PC form over the PSIS. You flex, the knee is flexed. Don't try to help me, okay? As I told you that sometimes when somebody tries to help you, that becomes very difficult. Next, hip is taken for extension. Okay? Hip is taken for extension. You can just lock it. You don't move your feet, okay? I'm just blocking the feet here. Hip is taken for extension, adduction. Mobilize and you can give a thrust. The direction of thrust is from the PSIS, anterior, superior and lateral. Barrier and give a thrust for posterior rotation dysfunction management. Along with this, as I told you that disc prolapse cases will be having mostly associated with this posterior rotation dysfunction. You can do the disc prolapse management. The prime cause for the disc prolapse is flexion, compression and rotation. Okay? Because it is associated with posterior rotation dysfunction, so I am just discussing about that. Prime cause for the disc prolapse is flexion. Somebody bending forward with some amount of rotation and trying to lift something. This is the most riskiest position for the disc prolapse to happen. Most riskiest position. Prime component is flexion. So in biomechanics, management principle are pretty simple. Flexion is the cause, extension is the remedy. You are having anterior rotation dysfunction, remedy is giving posterior rotation. You are having a posterior rotation dysfunction, remedy is giving anterior rotation. Correct? So, here as the flexion is the cause, so we are putting the spine in slight extended position. Okay? You can put one pillow anterior to the chest so that there is extension in the lumbar region. Understand the biomechanics here. Very, very useful technique and very commonly you will come across disc prolapse cases. You are putting it in extended position, so the vertebra is going like this. Bulge is here. Okay? General principle of manipulation, when we talk about the spine, we usually manipulate the upper vertebra. But here when it is going like this, suppose L4, L5, there is a bulge. You have put it this way. Mobilize the L4, okay, and give a thrust. It is going to push the disc in. Mobilize the L5 also, because it is like this. You can mobilize the L5 also and give a thrust. That also is going to push the disc, annulus fibrosus inside. I mean, the disc is going to go in, right? Nucleus, annulus gets cracked, nucleus comes out. So now, prone lying position, palpate iliac crest, L4, L5, PC form over the spinous process, give central PA, mobilize, and you can give a thrust. Don't immediately go with a thrust for a aggressive disc bulge. Preferably, go ahead with mobilizations. Central PA glide and central PA thrust. So, in addition, you find there is a disc bulge, you can go ahead with this management. Okay. Now, next coming to the piriformis or piriformis muscle. So, piriformis, it is one external rotator of the hip joint, right? It is one external rotator of the hip joint. Palpatory landmark, joint a line from ASIS to ischial tuberosity. ASIS to ischial tuberosity, one line. Another line from PSIS to GT. ASIS, ischial tuberosity, PSIS, GT. That intersecting point corresponds to the piriformis muscle. Now, anterior to the piriformis muscle, we have the sciatic nerve. So, when it is tight, it is going to compress and that is going to produce the sciatica. Patient comes and tells, I am having the back pain with some radiation. So, now what is the finding? Come down. Okay. Right. Down little bit. Okay. So, observatory finding now. Observe for the foot first. Hind foot and forefoot relations. If it is externally rotated, the calcaneus will be more medial and forefoot will be away. It will be, you can see this, it will be, yes. But now you compare both the sides, the right side it is like this, I mean forefoot is more lateral and hind foot is more medial. There is a possibility of tightness of piriformis muscle. Possibility, because it could be due to tibial torsion or femoral versions also. So, it cannot be taken for granted. But yes, we can think that okay, it can come in differential diagnosis. Yes, it can be a piriformis syndrome. Next step of confirmation. Flex it, flex the knee for 90 degrees and take it towards internal rotation. Now, biceps brachii is one flexor of elbow. When it is tight, it is going to restrict elbow extension. Similarly, piriformis is one external rotator of the hip joint. So, when it is tight, it is going to restrict the internal rotation. So, this is a more confirmed test. Go there and take both the hip for internal rotation. Now, compare both the side. Now, suppose compared to left, right side there is restriction of internal rotation. Say right side is coming till this, or right side and left side is coming till this. Say left side the internal rotation is restricted. That gives a confirmation that the piriformis in left side is tight. Okay. Once it is tight, we are going to apply the MET, muscle energy technique. There are different ways we can apply the technique. I will tell you one of the very common ways. Place the palm of the thumb over the palpatory point. Okay. Join ASIS to ischial tuberosity, PSIS to GT. Palm of the thumb. Go to the barrier. Ask the person to bring the foot to the midline. Okay, do this movement, right? Yes, and we restrict that movement. Bring it, and we bring it, and we restrict it. 1, 2, 3, 4, 5, 6 for about 6 seconds. Okay, and we repeat it for 6 to 10 times. Bring it. 1, 2, 3, 4, 5, 6. Relax. Then come to the new position. We bring to the new position and we repeat it for 6 to 10 times. Now, this is the method, usually with the thumb. Somebody with a big gluteal area, somebody with a, you sometimes see in the airports, airport we see a lot of people with, sometimes they sit in the middle seat and that seat is not enough. So for somebody who is nearly 1.5 quintals to 2 quintals of load, so thumb will not be enough. So in that case, you have to put the elbow, okay? And always take care of your spine. Now I am in a wide base stance. So wide base stance means we can bend from your knees if you have to adjust with the height. Avoid bending the spine more. Relax. Go to the barrier. Bring it. I think he slept. Are you okay? ठंडा मौसम में गर्मी लाइट का आ रहा है, अभी सो गया. Go to the barrier. Bring the foot to the midline. Bring. 1, 2, 3, 4, 5, 6. Relax. Come to the new position. Bring it. 1, 2, 3, 4, 5, 6. Relax. Come to the new position. Okay? So this is the management for the piriformis muscle dysfunction. And what you have to do is, as I told you initially, that in manual therapy principle, we are looking for 3 components. The passive component, that is the stability model. Passive component first, corrections. Next, active component corrections. Next, neural component correction. So when we talk about, you see sometimes what happens, somebody just refers one article in some journal telling that, specifically when we see about research publication cannot be at a time with multiple things. Research has to be very focused and it takes one component. Suppose one study is there where effect of core stability on the low back pain or effect of core stability on pelvic complex dysfunction. The person just goes and starts with that component. But the thing is, first, if you take the stability model, passive component, active component, next comes the neural component. I mean, when somebody is coming with severe anterior rotation dysfunction, that definitely cannot be corrected with immediately starting some core stability programs. First, we have to correct the, anterior rotation dysfunction, then go for the methods. So at a time when it reduces the symptoms for nearly 60%, you start the exercise programs. Okay, but nowadays, what is happening is I see patients coming and in first session, what exercises I will do? I mean, there are a lot of people who come with that query. So that you have to tell, just let the symptoms little go down for about 50-60%, then you give your exercise programs to them. That is how we can plan for one effective management. Okay? What I'll do is I'll take some questions now. Then after that, if somebody is having any low back pain, some 2 to 3 cases, we'll do some live demonstrations here. So now, since we discussed about biomechanics, pathomechanics, the various assessment techniques for the SI joint and for the pelvic complex, one more technique is remaining, one very important thing. This is about piriformis syndrome. Is there any queries till now? Maybe 1 or 2 queries. Yeah, please. You want a mic? You can tell.
At what NPRS we can apply the grade 3 glides and thrust?
See, it actually depends. Thrust somewhere the symptoms reduces about 40 to 60% maybe with pain rating scale near to about 4 to 5. Maybe that time you can give the thrust. Don't apply a thrust in very aggressive condition. Okay, so that may
aggravate the pain.
That aggravate the problem, and the patient will lose the confidence on you. Because the thing is, it is relatively more better and safe because to get a trust. So that is a part of cognitive behavioral therapy. the CBT. So CBT also has to be applied. Cognitive behavioral therapy is nothing but because that lot of work is going on under ISP. What I'll suggest you is that you get involved with International Association for Study of Pain, because ISP is one of the very finest professional organization I have seen in the scientific world till today, let me tell you honestly. Because we have, maybe other organizations will be there, but the scientifically if you are looking at, and ISP will have definitions. When we talk about the low back pain, okay, there is a definition of ISP, International Association for Study of Pain. So what I will suggest to you is that, how many of you are members of ISP? Okay, only one? Okay. But are you reading the journals, pain journals and all? Fine. And I think, I am running my foundation, Deepak sir is running Capri Institute. So from foundation we are now running the pain schools. We are going to start the pain schools, and Deepak sir, you also can start the pain schools, maybe under ISP, because there is a lot of grants for that. So we can apply for those grants, and we can involve people for those pain researches, because pain is something, it is having a more larger dimension. And what I will suggest is that those of you who are running clinics or you are running any kind of entrepreneurship, you can get associated with. I am a ISP member from a very long time, but still I think that I have to give little bit more time into the pain researches. But what is important, what I will tell you is that what are the important components under ISP guidelines when we approach from pain management is that when a patient comes to you, I am answering your queries. You can sit down. I have understood, and in continuous only I am answering to your query, so it makes easier to transfer some more, kind of informations. Now, when a patient comes to you, you would have heard, if you are a good clinician, patient comes and tells that I have gone to, including this thing I have heard from so many medical experts, because lot many professors I treat them, they tell that, see, even if I am having a back pain, I have gone to another consultant, I have not been heard properly. I think you will be agreeing with me, maybe Bina Pandey sir is there, or Deepak sir is there, Mona madam is there. Madam, is it correct? I mean, this is what many patients I come across. So first thing is that you allow the patient to express himself or herself. Very, very important. Correct? Now I will give a small example. Can you please stand up? You. Oh, yeah, fine. Yeah, one of you stand up. Yes. Fine. Just giving one example, okay? Speak 10 lines about yourself. Speak 10 lines about yourself. Just giving one example. Just giving one example. Fine, please sit down. Fine, yes, no, okay. My mic is there. Right. See, even if I tell arbitrarily to anybody that speak 10 lines about yourself, it is not easy. It is not easy, let me tell you. The person will stop, because this experiment I have done, I will ask, okay, speak 10 lines about yourself. Person may speak 5-6 lines. About, see, when in general you are talking about yourself, you are able to speak about 5-6 lines. A patient will talk to you. How much time a patient will talk? Maximum 1 minute, 2 minutes. Listen, don't interrupt. Listen. That is one of the main component of CBT, cognitive behavioral therapy. Okay? You take your case sheet, tell the person, speak. Patient is complaining, nobody is hearing. Give the opportunity. Patient will speak. I have never seen anybody speaking more than 2 minutes till now. Just document. Next step, you do your assessments. As we discussed, take a skeleton, take any model and explain to the person. See, you are having this problem. This is the thing. This is your spine or pelvis has rotated. For example, anterior rotation dysfunction has gone this way. I am going to correct it. Correct? So this itself, one understanding of the patient itself is part of cognitive behavioral therapy, because that misfired cognition is going to break. Then you can start, as she said, about somebody with high intensity of problems. Now, okay, she put me into a little bit difficult situation. She told me about a general low back pain, okay. Now suppose, first of all, I will see that whether it is a mechanical or not. It is a mechanical issue or it is any other issue. First ask whether there is any trauma is there or not. Now if it is nothing else is there, you rule out the complications. Now what are the red flag conditions? That also I will add here. Trauma, infections, severe infection is there. That also can produce the low back pain. Some severe infection is there. So you don't take in EBP, in evidence-based practice, you are not going to take anything in assumption. Correct? You have to reason out, examine, and then reach to the conclusion. You have got a disc bulge. Okay, I was bending forward. Okay, I will take severe back pain. One condition very commonly is the disc prolapse condition. I will tell the management for that, what you can do. Now, lifting something, suddenly got a catch, intense pain, 9, coming like this. Okay? Now, in that case, what you can do? You can go for positioning and you can give only gentle mobilizations. You can give mobilization, but gentle technique. But certain areas where there is more involvement, we have technique of positional release techniques. So PRTs are very safe to apply in very aggressive conditions. Okay? Did I answer your question? Fine. Any other question? Okay. Mic, please. One mic was there here, somebody kept.
Good morning, sir. I've been a big fan of you since the last decade, and learning from you is like a dream come true. I have a very silly question, sir. You taught us Gillette's test. So there's also a test called Trendelenburg's test. Trendelenburg's test.
Yes.
Sir, it's the same thing, like lifting your leg to see if the PSIS goes up or down. In Trendelenburg's test, if the ASI is lifted up, it is normal. Going down, the opposite side abductors are weak. Gillette's test tells you if it goes up, then it is abnormal.
No, in Gillette test, we are checking for the PSIS.
Sir, I'm talking about the PSIS only. In Trendelenburg's test,
it is more of a dynamic test. See, when you are standing or you are walking, either you are lurching it, waddling it, or you are having dropping of the pelvis, right? That is issue related to the muscular issue. Here we are checking for the dynamicity of the PSIS specifically.
Sir, if I just ask any patient to lift the leg up, sir, if the PSIS goes up, so should I take it?
No, we are doing a movement, no? We are doing this movement.
In Trendelenburg's also there is a movement, so you lift your leg
Trendelenburg, you are doing this.
Okay.
Trendelenburg, you are doing this.
Okay.
You are doing this. Here you are doing this.
Okay, thank you, sir.
Here,
Sir,
there is a knee flexion.
there is a
Trendelenburg.
hip flexion.
No,
In Gillette's is a hip
Gillette's
flexion.
is a hip flexion.
Okay, thank you,
Here
sir.
basically in Trendelenburg we are offloading. You do hip flexion or knee flexion, we are basically offloading it. We are putting the load on one side.
Yes.
Here we are creating a dynamic hip movement.
Okay.
So there is a difference.
Sir, my second question is, I have
But
seen...
sometimes associated with this pelvic complex dysfunction, you may get gluteal weakness also. So that time you need to work on the gluteals. That time you can check for both.
I understood, sir. The one is not flexion is there, one flexion, hip
Another
flexion is
thing
not
is
there.
you can go for the dynamic test, na? In Trendelenburg you will get those.
Trendelenburg gate, yes.
Here you will not get that.
Okay, sir. Sir, my second question is, many of the patient I've seen there is a lump on the PSIS. It's called termed as sacral mouse.